Good evening all to the weekly huddle. My name is Anup Agrawal. I am an interventional cardiologist at Care Hospital, Hyderabad. Most of the attendees here for today, I know them personally and they have joined us previously as well. I'm joined by my colleague and co-host for the session today, Dr. Praneeth Polamari. He is also a cardiologist at Care Hospital, Banjara Hills itself. So the huddle is an audience level interaction session where we discuss a variety of things, mostly focused around healthcare. We typically pick up a topic or a clinical case and we try to restrict our discussion around particularly that topic. The basic premise of the huddle is to bring our casual hallway discussion to a more organized platform like this one and share our ideas together. While we do want to talk about science, the huddle particularly aims to bring out the practice patterns that we have and understand the rationale of what makes us take a particular decision. Because we recognize that a lot of us, we have our own thought process based upon the local factors, based upon practical scenarios, and also taking into account the science which is available. The huddle is hosted every week on Wednesdays, like today, at 7:30 p.m. And this is our 24th session, for which our topic is antibiotic prophylaxis for infective endocarditis. Typically, to facilitate the discussion like this one, we do invite a few of our colleagues. Today, I have invited Dr. Srinivas, who practices dentistry at Care Hospital, Banjara Hills. And we may be joined with a few internal medicine physicians down the road, we'll see. The huddle is not a speaker and audience model, rather an audience level interaction, which means that any of the attendees who have to share their thoughts, they can simply unmute yourself and share their thoughts, or they can raise their hands and I will unmute you and you can share your hands. As a courtesy, you should wait for others to finish their thoughts before you unmute yourself. So with that, I will get started. Typically, I have a clinical case just to get things started with the discussion. I ask Praneeth to put his input, and then we open it up for an audience level discussion. So Praneeth, this is a clinical case, and again, we try to keep all the clinical cases which we saw practically so that, we don't talk about what ifs, we talk about what happens on the ground. So Praneeth, this is a 48-year-old female. I have been following her for the past 2 years. I inherited her 2 years ago from one of the cardiologists. She has a history of mitral valve prolapse with moderate to severe mitral regurgitation on echocardiogram. Few echoes shows moderate, few echoes shows severe. She is totally asymptomatic. Her LV dimensions are okay, and her LV ejection fraction is more than 60%. She is otherwise functional class 1 and does not report any symptoms. She is also hypothyroid, for which she takes thyroid supplementation, and she is doing fine with that. Very recently, she started having problem with one of her wisdom tooth, and she seeks tooth extraction for that. Somebody told her that because you have so-called valve disease or heart disease, you need to take some antibiotics as a prophylaxis before you go for tooth extraction. So here is a clinical scenario for you, Praneeth. 48-year-old female, mitral valve prolapse, degree of regurgitation is somewhere between moderate to severe, asymptomatic, otherwise all right, needs to go for tooth extraction. What is your recommendation for antibiotic prophylaxis for this patient?
Yeah. So I would ask them to give injection ceftriaxone 1 gram IV half an hour before the procedure and go ahead for surgery. That would be my recommendation, and followed by one more dose of same dose, 1 gram of ceftriaxone IV 6 hours after the procedure. That would be my recommendation as an endocarditis prophylaxis for this patient.
Okay, so Praneeth, I'm going to follow up on this and then we'll open it for discussion. So you, first of all, you do want to give her prophylaxis, right? Okay. I'm going to keep you unmuted, Praneeth, for the time being because I'm going to ask you a few questions. So give us your rationale. Why do you want to give antibiotic prophylaxis to this patient?
It is having a regurgitant valve lesion, which is moderate to severe. So because there is severe regurgitation, a pre-existing valvular heart disease is a indication to, or it's a predisposing condition to have an endocarditis. That is where I would recommend to give endocarditis prophylaxis. Dental procedure which involves a lot of bacteremia. Uh, Combining both together, I would prefer to give endocarditis prophylaxis.
Okay, the follow-up question there is, you also chose to give post-exposure prophylaxis. Is the rationale the same for post-exposure or something else?
Uh,
You also chose to give her post-exposure prophylaxis. You told that you will give another dose after 6 hours.
yeah,
So is the rationale for post-exposure the same or different?
same. Trying to be a bit
Okay.
cautious. That is where I am giving it again.
And did you say the dose as well? You said 1 gram, right?
Yeah, 1 gram IV ceftriaxone.
Okay. The third question is why injectable, why not oral? Just trying to understand why you made that decision.
When you are hitting it, hit it hard. Try to cover much that comfort of knowing that injectable works better than oral, and endocarditis is something which I fear. So I am trying to be more cautious here.
Okay, now the last question. Dental extraction, tooth extraction is an outpatient procedure. If you instruct the patient or the dentist to say that you're gonna need another antibiotic after 6 hours, particularly injectable, the patient needs to be in the hospital. Your rationale of giving IV antibiotic, do you think it is worth spending another 6 hours in the hospital? You can justify that, is what I'm trying to understand.
So in this patient who has moderate to severe mitral regurgitation, I would prefer to take that extra step in being cautious, gradual approach, because again, because there is, I would be stretching forward, take that extra step.
Perfect. Thanks, Pranit. I'm going to mute you, and I'm going to ask few of my cardiology colleagues who are in the attendees here to get their thoughts, and then we'll go to Dr. Srinivas, for whom this actual patient will come to. So let me actually, and whoever is unmuted, I'm just going to mute you, sorry. So let me ask Dr. Srinivas. Dr. Srinivas is my colleague cardiologist at Care High Tech. Dr. Srinivas, you have a 48-year-old female, mitral valve prolapse, moderate to severe MR, asymptomatic, needs tooth extraction. IE prophylaxis, yes or no? If yes, which drug? If no, why not? Dr. Srinivas.
Yeah, yes, Dr. Anup, I agree with Praneeth that we can give it before the procedure, but since the duration of procedure is not going to last for maybe say more than half an hour or 1 hour, that dose of ceftriaxone would still act for a couple of hours. So probably we don't need to give it after 6 hours again.
Perfect. Thank you, sir. Let me ask one more. Dr. Chandramukhi. Dr. Chandramukhi is a senior cardiologist at Care Banjara, and she pretty much single-handedly mans the non-invasive lab. Dr. Chandramukhi, you have a patient here, 48-year-old female, MVP, moderate to severe MR, needs tooth extraction. Prophylaxis, yes or no? If yes, which one?
Good evening. Yes, I will give infective endocarditis prophylaxis to this patient. As Pranit has already mentioned, we will give IV ceftriaxone. And as you were concerned, like for post-procedure prophylaxis, the patient may need to stay back into the hospital for 6 hours. So in such cases, because already he is having mitral valve prolapse and severe MR, moderate or severe MR, which carries high risk for infective endocarditis. And as per our Indian setup, again, the risk increases. So post-procedure prophylaxis also I would like to give, and in such patients I would like I would do the procedure in the morning, first hours of our OPD procedures, and then so that it will be convenient for the patient to stay back 6 hours in the OPD and get the IV prophylaxis post-procedure, or they can get the post-procedure prophylaxis in the nearby clinic or a nearby nursing home. Thank you.
Thank you so much, ma'am. If I could invite Dr. Sai Vittal. Dr. Sai Vittal, I don't know if you're able to hear me or not. I'm going to unmute you. Sir, if you could share your thoughts about this particular case, how would you approach?
I would approach the same as Dr. Pranit Polamuri would have done it. A initial ceftriaxone 1 gram injection, followed by another injection. Usually, I may time it after 6 hours or 8 hours. That's what I would do, repeating the same dose after 6 hours, a post prophylaxis.
Perfect. Thank you so much, sir. So let me give you a 2-minute background on this, maybe 3 minutes, and then we'll go to Dr. Srinivas to see what his thought is. So if we look at the infective endocarditis prophylaxis business in terms of what the recommendations are or what the societies would say, then we can kind of divide the world in what we were doing in 1990s, then what we were doing in early 2000s, and then what we were doing in the last, or what we are doing in the last decade. And truly speaking, if we talk about data-driven or evidence-based medicine, prophylaxis for infective endocarditis is a classic example of where we absolutely don't have any data, and we are most likely not going to get any data because of the kind of disease that we are dealing with. It will require a very large sample size, and it's just going to be impossible. So in 1990s, or I would say before year 2000, there was a lot of this thought process that infective endocarditis is bad and we should hit them with antibiotics so that you prevent infective endocarditis. In fact, I remember there were classification of what kind of cardiac pathology you have into low, intermediate, and high risk pathology, so-called. And then every single non-cardiac procedure, you name it, like skin incision and drainage, or cystoscopy, or Foley catheterization for that matter, vaginal deliveries with C-section or not, and then bronchoscopy, endoscopy, biopsies, colonoscopies, and the host of dental procedures, they all were again classified into their risk of bacteremia versus high or low. And then there was this complex algorithm in terms of trying to figure out which patient would get or not. And what ended up happening was most of the patient, at the side of caution, we would give antibiotics. Over the period of time, there was some data looking at the risk of bacteremia with every procedure. And time since then, what we have observed is that transient bacterial translocation happens far more commonly with our daily activity, like brushing your teeth, like if somebody has a diarrhea or something of that sort, these transient bacterial translocation are far more frequent than what we think, and to a certain degree, their level of bacteremia matches or even increases or even is higher compared to some of the procedures for which we are giving endocarditis prophylaxis. And then the third rationale was that, okay, we are still giving endocarditis prophylaxis, but is it actually working or not? So we really did not have any of these clue in terms of whether it is justified, in terms of is it actually needed? And even if it is needed, by us giving the therapy, are we making any difference? Are the endocarditis risks going down? And we really have no idea. So I remember when early on I joined training at that time, there was this big debate because the newer guidelines at that time came, I would think maybe late 2000s or early 2010. I can't remember the exact year when this new guideline came, which pretty much discounted all the procedures, everything that we were doing in 1990s. And then towards my end of training, maybe in 2015-16, a new set of guidelines came, which pretty much said, don't give endocarditis prophylaxis. Like literally, I remember UK guidelines that clearly say, don't give endocarditis prophylaxis, not because it doesn't work, but because we just don't know. And the risks of giving blanket antibiotic therapy probably exceeds that of the benefit that we may get. So the new thought process that came was, rather than identifying which patient has the highest risk of getting infective endocarditis, which was the thought process in the last 20, 30 years, the new thought process was forget about which patient has the highest risk of getting infective endocarditis. Let us identify which patient will be hurt the most if they get infective endocarditis. So which patient, if they get IE, it becomes a big disaster. Like for instance, a heart transplant patient. So heart transplant patient, people say that you shouldn't get endocarditis. So those patients you can give antibiotics, even if it means you are over treating it, because those patients you don't want to get a bad disease in form of endocarditis or whatnot. So rather than identifying cardiac pathologies which are high risk to cause IE, the thought process changed where we started saying that, okay, let's identify those patients on whom having an IE is going to have a far more devastating consequence than the chances of having IE. And there we started prescribing antibiotics and all this. So I'm just giving you an overall journey of what happened in the last 3 decades, where we started with giving prophylaxis to everyone, to most recent where UK guidelines say that don't give it to anybody. And rather, if you have to give it to somebody, then give it to somebody whom you think IE is going to cause more damage than other situation. So not just pathology based, but a patient level based. So that was the overall thought process. Going by the guidelines, this patient in the current era will not fit for an antibiotic therapy. But the whole idea why we discuss these things, particularly in meetings like this, is because we just don't want to go by the guideline. We want to understand what is at the ground, and we want to make decisions based upon what we think is clinically right, rather than just what guidelines or societies say. So that was my background, and then maybe we can elaborate this over the discussion if the questions come. But let me talk to Dr. Srinivas. Dr. Srinivas is our chief dentist at Care Banjara. Sir, this patient comes to you for tooth extraction, and we are not talking about perioperative antibiotics. That is different. Perioperative antibiotics we give even for a patient who comes for cellulitis drainage. We are talking about antibiotics for IE prophylaxis. Dental tooth extraction, MVP, moderate to severe MR. Let's say if this patient would have come to you first and not to me, would you have given IE prophylaxis? If yes, which drug? Dr. Srinivas.
Yep. Good evening, everybody. See, basically, we are treating a lot of cardiac cases, so we stick on to this protocol of giving infective endocarditis prophylaxis, selecting the patient. In dentistry, basically, we, after 2007 American Heart Association guidelines, as Dr. Anup said, this is not required. The transient bacteremia will be there through daily activities, and the bacteremia will be for a longer period. I agree for that. But there are two different schools of thoughts. One set of people giving and one set of people not giving. And my opinion, or I rate I grade my patients like mild, moderate, severe procedure. According to the procedure, I decide. If I enter the tissues, that means I use a scalpel or I incise molar extraction, a lot of guttering of bone is there, and a lot of time we spend with the patient doing procedures, manipulation of the oral tissues, then definitely I do take any cardiology patient. I take opinion or clearance from the treating cardiologist. Then all these years we were treating with prophylactic antibiotics only. Yes, post procedure, definitely. Sometimes we switch over to oral drugs immediately after 6 or 8 hours. But pre-procedure, we are doing it. If it is a surgical case, if it is a non-surgical case, yes, we can put the patient on coverage of antibiotics. Like in dental procedures, what we do as a department protocol is we start all the patients with antibiotic coverage 24 hours before, or stat dose of 1 gram. So I prefer that way. And all this, believe me, since 2003, I was working in care, and to my knowledge, there was not even a single case who landed up into endocarditis due to dental procedure, which is untreated or unrecognized, will be fatal. So I believe in this thought of giving prophylactic antibiotics. And as said, there are animal studies. They indicate definitely the use of antimicrobial prophylaxis, which are really effective. But some human studies as I told, there are two different schools of thoughts. I think I follow this. I told you what I followed all these years. Is there anything else I can?
No, sir. We'll keep coming back to you as
Yep.
as and when question comes. Let me ask some other people's thought. And again, as I said, that this is more of a practice-based approach rather than guidelines. Because if you go by the guidelines, I will tell you. Let me just go through what currently is written on paper. So the current guidelines would suggest that you do infective endocarditis prophylaxis when both the conditions are met. And two conditions are: condition number one, where the cardiac pathology is very high risk, and condition number two, where the non-cardiac procedure that you are doing carries a very high risk of bacteremia. So the number two is very easy. The number two is essentially just dental procedures that require gingival manipulation. That makes it very easy. So your routine cleaning does not require antibiotic prophylaxis. On the other hand, if you are doing some root canal treatment, if you are doing dental extraction and all these, then that comes as a high risk. So that part they have taken care of. They don't mention any other procedure as high risk of bacteremia, none. Then about the cardiac pathology, they have 3 or 4 criteria which are easy to remember. If you have a bioprosthetic valve, if you have a prosthetic valve, bio or mechanical, you are classified as high risk. If you had infective endocarditis before, you classify as high risk. If you had a valve repair, either with endoplasty ring or whatnot, you are classified as high risk. Cardiac transplant patient with any kind of valvulopathy classifies as high risk. Congenital heart disease, which is either unrepaired cyanotic or repaired but has got a residual shunt, that classified as high risk. So these are pretty much all the criteria that the most recent guidelines would suggest. So MVP is out, native valve disease is out, ASD, VSD is out. All these situations which earlier were so-called classified as intermediate risk, they're all out. So very restrictive guidelines per se currently, and most of the cardiologists whom I interact with, they would say that they don't follow this restriction. They actually prescribe antibiotics in a more generic population than this. So that is over the guideline. Let me ask some of the other audience in terms of what their thought is. Dr. Ali, Dr. Muhammad Ali, I'm unmuting you. I will ask you about this particular case, and then I will ask you some other situations. So Dr. Ali, 48-year-old lady, mitral valve prolapse, moderate to severe MR, tooth extraction. Would you give IE prophylaxis, yes or no? And if yes, what? Dr. Ali, your thoughts? Sorry, we can't hear you. Dr. Ali, we are not able to hear you. Okay, we'll get back to you. Let me get Dr. Prithvi's thought. Dr. Prithvi, I'm unmuting you. If you could share your thoughts about what you would do.
Sir, hello, sir. Good evening, sir. So I'd also ask them to get an injection of ceftriaxone, sir, IV 1 gram, 30 minutes before procedure, sir. But I usually don't give post-exposure prophylaxis, sir.
Perfect. Thank you. Thank you so much, Dr. Prithvi. Let me ask Dr. Sahithi. I don't know, Dr. Sahithi, are you able to hear me? If you are, if you could just share your thoughts about this particular case. Dr. Sahithi, we are not able to hear you. Unfortunately, we can't hear you, Dr. Sahithi. Okay, we'll get back to you. Let me ask someone else. Dr. Shankar, I'm unmuting you. If you could share your thoughts about this particular case, and then I'll give you one more case scenario. Dr. Shankar.
since a long time. Earlier, we used to give prophylaxis for the mitral prolapse, even ASD, VSD, and but of late, the guidelines have been changed. Recently, even this mitral prolapse also is not included in the infective endocarditis prophylaxis, but clinically, with our experience, I have seen cases with the infective endocarditis, patients of mitral valve prolapse. I have been following a family of mitral valve prolapse syndrome. One of them, he had a fever for more than 3 weeks. So we investigated. I know that he is a case of mitral prolapse. So we did echo and we found vegetations. So with this, we burnt our fingers. So for any procedure, I like to give prophylaxis, even for the mitral prolapse. If it is not indicated, even if it is not indicated in the guidelines, but I prefer to give prophylaxis because I have seen cases with infective endocarditis in these congenital defects. So I give ceftriaxone. Earlier we used to give ampicillin and we used to repeat after 6 hours. But now we are giving only ceftriaxone 1 gram 1 hour before the procedure. This is my way of approaching to the case of mitral prolapse with moderate to severe MR.
Dr. Shankar, I'm just going to ask you a few follow-up questions. So the rationale is infective endocarditis exist. They are there. And I don't think that we will be able to completely negate it because there are so many activities that we do which causes bacteremia and some of which may translate into infective endocarditis. The question here is, do we think that these antibiotics work? I mean, one idea is, can we do anything better? And we probably can't. I don't know of any other foolproof way of preventing infective. It's something like for this whole COVID thing, when we started giving all these drugs, not because we thought these drugs work, but because we didn't have any other good alternative. So whatever we had, we were just giving. So do we think that these prophylaxis actually work, or we are doing because we don't have a better alternative? What is your thoughts on it, Dr. Shankar?
Actually, to be frank, actually this prophylaxis may not be sufficient enough if the cardiac pathology is severe enough. But only to save our own skin, because of the consumer forums and all, we should follow. We are compelled to follow the guidelines. But practically, this only 1 gram ceftriaxone works in these cases. I don't think, because even after giving ceftriaxone also, or ampicillin or clindamycin, we get cases of infective endocarditis also, and where they need 2 to 4 weeks of antibiotic therapy. This is my opinion, because this may not be sufficient enough, but era of this consumer forums and all, whether you have given prophylaxis or not, somebody will question it. That's why we are giving this prophylaxis. But practically, in my experience, I have seen, even after giving prophylaxis also, we have seen cases of infective endocarditis.
Thank you so much,
Well,
sir.
I will leave it to other doctors' opinion, but this is I have seen in my clinical practice.
Sir, this is a very important aspect that you said, that if you don't give antibiotic, or if you give antibiotic, if patients develop infective endocarditis, either ways, then in a situation where you have not given antibiotic, you may be questioned for your decision. And that is difficult to defend. On the other hand, we giving antibiotic and patient developing, let's say, diarrhea or God forbid C. diff or whatnot, that is a easier thing to defend on the forums, as to speak, or even in a clinical seminar, versus when a patient gets an endocarditis. So that's an absolutely valid point. I'm going to pause here for a minute. I would invite if anybody has got any thoughts to share on this particular topic. If anybody has any thoughts, they can unmute yourself, or I'll go forward with it. I'll just pause for a few seconds for anybody to gather their thought. Okay, Praneeth, I'm unmuting you. We'll just, because this is a very direct scenario, I'm just going to ask you a few questions, and then you tell me what you would do in these patients. So
Sure.
mitral valve prolapse, same patient. Okay. So now I am just making it up. Up till now, I was telling you a real patient. Now I'm just making it up. So the same patient, let's say this patient is going for a bronchoscopy, i.e. prophylaxis, yes or no?
No.
Bronchoscopy with a peribronchial biopsy using bronchoscopic ultrasound.
Yes.
Yes. Tonsillectomy or adenoidectomy?
Tonsillectomy. Adenoidectomy. Yes.
Endoscopy?
No.
ERCP?
ERCP. No.
Cystoscopy?
No.
This patient, let's say if she was 34-year-old going for a C-section, she will get antibiotic for C-section, but we are particularly asking for infective endocarditis.
C-section. Yeah. Yes.
Okay, perfect. I'm going to ask you questions about cardiac pathology particularly. So
Okay.
if this patient did not have MVP, if this patient just had moderate to severe MR, let's say because of LV dysfunction, and going for tooth extraction, would you give prophylaxis to this patient?
Yes, Anup.
You would. So
Yeah.
even for a regular valvular pathology, you would give antibiotic prophylaxis to this patient.
Yes.
Right.
So yes. So my I fear endocarditis, as I said,
Right.
and most of our procedures or our practice of using sterilized things or G things, so to speak, and that risk of uh, infections, the sterilities and all those things are of a concern. So that is where you fear endocarditis, or I fear endocarditis, and I tend to overdo some things.
Okay, so let me again make things very clear. So what Praneeth is saying is that the equipment or stuff that we are using, we are not very confident of the kind of sterility that is required, and point well taken. Remember, infective endocarditis prophylaxis is given not because of the sterility of the procedure, that is taken for granted. Infective endocarditis prophylaxis is given for the bacteremia that is induced by your procedure, regardless whether you are using equipment with a completely sterile technique or equipment with is less. Praneeth, let me ask you a question, okay? And this is very pertinent. And I'm just discussing this because it is part of the discussion, not because I'm refuting what you are saying. So let us say somebody gets a gingival manipulation and with a valvular disease, and this patient you think deserves antibiotic prophylaxis, because we all fear infective endocarditis. I fear infective endocarditis as much as you do.
Okay.
Now, let's say a patient is going for an angiogram. Here you are actually accessing vasculature directly.
Correct.
Right? On the tooth part, there is a chance that you may be accessing vasculature.
Correct.
But in angiogram, you are directly entering the vasculature using a reused equipment.
Very true.
In a scenario which is not sterile, which is not completely sterile, I would say. It's not non-sterile, it's not completely sterile. Right? Cath lab situation is not completely sterile.
Correct.
Right?
Yes.
Why are we not giving endocarditis prophylaxis or perioperative prophylaxis in diagnostic angiogram cases? You understand where I'm coming from?
Yes. I completely getting you what you're saying.
Okay.
So probably we are thinking irrationally, is what I think. I don't know. It didn't occur to me that, yeah, that process is valid, but it didn't occur to me.
Okay. Dr. Srinivas, your thoughts on this, and just thoughts on anything that we are discussing.
Yeah, Dr. Anup, did you say like mitral regurgitation secondary to annular dilatation or a fixed mitral valve?
Annular dilatation.
I don't think infective endocarditis prophylaxis is required there. If the pathology is due to annular dilatation, then we don't need to give infective endocarditis prophylaxis. Same is the case with mitral regurgitation, wherein it is because of failure of coaptation because the posterior wall is not contracting well. Even that is not an indication for infective endocarditis prophylaxis.
Okay, so sir, be here for a second, and I'm just playing devil's advocate. Believe me,
Right.
I would give prophylaxis for this patient as well, but I'm just for the sake of discussion. So, when you are talking about indication of infective endocarditis prophylaxis,
Right.
even mitral valve prolapse patient with severe MR going for tooth extraction in the current scenario does not have a established indication for prophylaxis. Let's make it very
Right.
clear. When we
Right.
talk about indication, it does not exist. So we are talking about what we think we should be doing. Because if we go by the textbook, mitral valve prolapse in the current era should not get antibiotic prophylaxis. Now, nobody is going to sue us for giving one because at the end of the day, it's our clinical discussion. So my question to you is, severe MR with MVP, in your opinion, needs antibiotics versus annular dilatation severe MR does not need prophylaxis. Can you defend that? Why? What is special about MVP?
See, probably MVP is a structurally damaged valve. Even MVP actually is not really indicated. Neither is HOCM. Even HOCM with MR is also removed now.
Absolutely. It's all removed. Yes.
Yeah, it's all removed. Whereas in a rheumatic heart disease with a MR, it's a structurally damaged valve. Definitely there it's an indication because the valve is damaged per se. And that is the subset wherein there is when there's a bacteremia, there's more seeding on a structurally damaged valve. Whereas when there's annular dilatation wherein the valve is not coapting, the valve is not really structurally damaged. It's only the annulus which is dilated. I don't think there is a more chance of seeding of bacteria there.
Okay. Okay. Let us continue this thought. Dr. Chandramukhi, let me have you in. I'm going to unmute you. Can you just take on this discussion from here on? What is so inherently different about MVP that we need antibiotics and we don't need antibiotics for other kind of valve disease?
In MVP, the valve is structurally abnormal, and there is some, like as Srinivas has already mentioned, it is structurally abnormal, and there is some damage to the tissue, and there is some accessory tissue. And on the top of that, there will be mitral regurgitation. So the risk will be more for infective endocarditis. In functional ischemic MR, as we were discussing, so in that the valve is structurally normal, and because of the LV pathology or atrial pathology, there is a mitral regurgitation. So in this case, as compared to mitral valve prolapse, because of the structurally normal valve, the risk of the endocarditis will be less in the functional ischemic MR. So in these cases, infective endocarditis prophylaxis is, according to me, it is not required in functional ischemic MR, but definitely, even though mitral valve prolapse with severe MR, it is not indicated in the guidelines, but because of all the discussion we have discussed, because of the sterility issues and these things, we give prophylaxis in mitral valve prolapse and congenital heart disease.
So, ma'am, I have a follow-up question on that, which I was discussing with Praneeth. I'm going to ask you the same question.
Yeah.
A mitral valve prolapse patient with severe MR going for surgery, you are doing a pre-op angiogram on that patient.
Yeah.
Antibiotics or no antibiotics?
We will give antibiotics in all the patients who are taken up for diagnostic angiogram, who are having mitral valve prolapse or aortic stenosis, or even in patients we do like mitral stenosis patients who undergo PBMB, or even in mitral stenosis patients who require angiogram. In my personal practice, I will give infective endocarditis prophylaxis even when I am doing angiogram for these patients.
Okay, now we are talking something else. Thank you so much, ma'am. Let me ask why Praneeth has been doing this malpractice. Praneeth, how many times have you given antibiotics in these patients whom you do pre-op angiogram?
So patients who have valvular disease,
Uh,
yes, I have given them antibiotic.
for angiogram?
Yes.
Okay, because then I'm the only person who has not given antibiotics in angiogram. Okay, is it the practice here? I don't know. Anybody in the audience, please unmute yourself and tell us what you do. Pre-op angiogram for valvular disease. Do you give antibiotic prophylaxis for infective endocarditis? Anyone, please unmute yourself. If you do angiogram in your routine life, your routine professional life, then I'm sure you have done preoperative angiogram for valvular disease. Do you give antibiotic prophylaxis?
Dr. Anup?
Yes, sir.
Yeah, for rheumatic heart disease, yes, definitely yes.
Hmm.
For bicuspid aortic valve, again, I think it is removed now.
Hmm.
And for MVP, there's a subset where they say MVP with a thickened mitral valve and a regurgitation, yes, you can give it. But if the valve is not, and if it is only mild MR, you can still not give it. That's what the guidelines say. But again, yes, for rheumatic heart disease, definitely I'm giving for all my patients.
Okay. Okay. Because this is something that I don't think I have ever done in angiogram scenario. Let me ask some senior guy to see what his Dr. Sai Vittal. You have been practicing for far more number of years than what we have been. Just educate us. What do you do in your practice for angiogram pre-operative?
Sir, previously, from coming from the fourth edition of downward to the 10th, the indications have been reducing year by year, edition by edition. That is the first thing. Actually, in the old editions, what was there has been continuously followed despite the new editions coming. And I think we go from with prophylactically doing angio, this endocarditis prophylaxis is better, especially when a regurgitant lesion, mitral valve prolapse, regurgitant lesion, we do it. And actually, as you have said, since ESC 15, there is no indication for these things. But still, we practice the old practice, we continue doing it.
And sir, do you do it for angiogram as well, or you do it only for the dental and other procedures?
Not for angiograms. Sir.
So pre-operative mitral valve prolapse, you are not giving antibiotic for
Yes.
angiogram?
No, sir.
You're not. Okay, so I'm not the only one who is not doing. I feel a little bit better. Okay, all right. Let me get Dr. Srinivas here again. Dr. Srinivas, I'm going to ask you a few specific
Yeah.
questions.
No, just one thing. The reason
Yes.
I give the antibiotic is anyway, the patient is going for a valve replacement. I'm more comfortable that he goes for a valve replacement without any possibility of infection. I don't want a prosthetic valve infection. So it's okay to give an antibiotic rather than taking a chance of some remote possibility of an infection.
Right. See, again, I'm going to reiterate this whole thought process that are we all afraid of infective endocarditis? Absolutely, yes. Can any of these procedures cause infective endocarditis? Absolutely, yes. Are these procedures at higher risk of causing infective endocarditis than some of the routine procedures like brushing teeth? We don't know that. And do giving high dose antibiotics before and after this procedure reduce the risk of infective endocarditis compared to those patients who don't receive these antibiotics? And that is also we don't know yet. So out of the four things that I told you, the first two, nobody is questioning that. We all fear and we think some of these procedures do induce endocarditis. But the other two, the answer is not yet very clear. In fact, more and more that people have learned, that is why it probably took them 30 years to downgrade their recommendation rather than 5-7 years, because most of the recommendation was based upon like a common sense or compromise rather than good data, because I don't think even they have good data about it. Let me ask Dr. Srinivas Akula about few particular things. Sir, I'm unmuting you. So Sir, these patients who come to you with cardiac problem, which I'm sure a lot of patients come to you because you are working in a center where inherently there are a lot of cardiac patients.
Yes.
Not particularly about the procedure. Is there something you guide them about their daily life as well to reduce infective endocarditis, like brushing their teeth or whatnot? Or that is all hokum? Like, does it really work?
No. Definitely, there are studies that maintaining very good oral hygiene definitely will reduce the risk of this. See, when definitely there are studies which have done without prophylactic antibiotics also, but where prophylaxis is oral prophylaxis per se, like hygiene of no gum disease, no periodontal disease, or no abscess, anything, uh, then definitely we can take a chance, but not all cases. As I told, high risk cases definitely we have to give, because mortality, morbidity, all these things come into picture, and will be as other doctors said, suing is also there nowadays. So, and we don't want our patient to go into trouble. In India, over the counter antibiotics are also available. So what I feel is patient might have exposed to other antibiotics also. Some resistant strains would have been there in them also. So it is always better, I feel.
And sir, how about teeth cleaning practices like usual brushing and whatnot? Patients with valvular heart disease, in your opinion, should they brush their teeth just like regular everybody else does, or do you think they should be relying more on mouthwash with somewhat brushing to reduce translocation? What is your thought process on that?
No. See, mouthwash and all can be done, but regular brushing is important, because interdental crevices and all you can't remove with just rinsing or rinsing around with mouthwash and all. Definitely, brushing is a must to maintain hygiene. The other things acts as an adjuvant, but they are not the things to be followed up. Brushing twice in a day. Basically, nighttime brushing is more important because salivary secretions are less, and you have to be really careful in retaining all the food debris in between your teeth or in the pockets which have created already in existing pathological diseases like pocket formation or intrabony defects, all those stuff.
And how about dental flossing and valvular heart disease? Does flossing make endocarditis more likely? Is there any data to suggest that, or your opinion?
If it is properly done, you won't go and hit the crevice there in the sulcular epithelium. What we call is, you don't really go into the sulcular epithelium. There is something called as junctional epithelium, so nothing will cross this barrier. So that time it's okay, but overzealous for flossing definitely is not recommended.
Perfect. Thank you so much, sir. That was very appreciative. Praneeth, I'm gonna get back to you again. Just few additional discussions. Your post-hour patient is going for a endoscopy, no biopsy.
Yes.
Prophylaxis or no prophylaxis?
Yes.
Why? You just told me 10 minutes ago that endoscopy you don't give prophylaxis.
You buy prosthetic valve. It's a 25 lakh valve. I don't want it to be infected.
But the question here is, by giving antibiotics, you prevent the risk of endocarditis.
I want to have a peace of mind. I
Okay.
don't want to feel myself guilty, so I will give an antibiotic rather than feeling myself guilty that I would have missed an opportunity and fear that the patient might come back with an endocarditis.
Okay. So this is a question that is open to everybody, and Praneeth, if you want to answer, you can answer, or anybody else can answer. So we are talking about one of the reasons why the guideline or the societies were compelled to even revisit this thought process in the last 25 years. Because if things were working fine and if everything is okay, there is no new data, then why unnecessarily to revise guidelines even when there is no new upcoming data? And one of the necessity of why the guidelines needed to be revised is because if we are not benefiting patients by giving antibiotics, then the whole notion of we are not harming either may not necessarily be correct, particularly when we are talking about so-called a routine implementation of these antibiotics. Now, I do agree to a lot of extent that in the Indian scenario, particularly with everything that we discussed, where these patients, they are exposed, in fact, multiple times exposed to antibiotics, and they may be taking far more antibiotics by themselves than what we are going to give as a prophylaxis. I remember there was one center who used to give 7 antibiotics for a pacemaker implantation. I could never believe myself. But that center was giving 7 antibiotics and discharging on 5 antibiotics on a patient whom they would put a pacemaker implantation, and that person's basic rationale was, I don't want a single pacemaker infection. Now, I also don't want a single pacemaker infection, but whether giving 7 before and 5 later, whether that is better than giving 1 before and 1 after, that I don't know. So the whole notion of giving antibiotics is not necessarily risk-free is what I'm trying to say. But I also hear the idea of the place we are working at, which not necessarily is conducive to the basic science. We talked about our sterility, we talked about our hardware, we talked about our patient mindset, we talked about our own peace of mind, and we talked about the litigation and whatnot. But even with all of that, is it worth? And that is what we are trying to discuss. Praneeth, I have one question, and then whatever I said, if anybody has any thoughts, please unmute yourself. The whole rationale of doing this is to get your thought process. Praneeth, one of my question is, now there is some sign, there is some data about it, okay? So when we look at the overall antibiogram or microbiological aspect of endocarditis, what started early on with strep viridans, in fact, in 1970s and 80s, I was not there at that time practicing medicine, but what I read from the articles is, at that time, if somebody has infective endocarditis, you can write strep viridans and you will be correct 90% of the time. Now, things have changed where we are seeing more enterococcus and we are seeing more staphylococcus than more strep viridans. In fact, I can ask you, when was the last time you saw an endocarditis which was strep positive, strep viridans positive? So my question to you is, if we really want to prevent, then the drug of choice in the current era should be vancomycin and not ceftriaxone or amoxicillin, if we really want to prevent, because the bacterial system has changed altogether. What is your thought on that?
Yeah, valid thought, Anup. As you rightly said, most of the organisms that we are seeing is the multi-drug resistant kind of a thing, or what you already mentioned. But again, vancomycin is a drug which is something which is more cumbersome to deliver. It has its own issues, so you're not comfortable giving vancomycin because of whatever that you can say, renal failure, its reactions, Redmond syndrome, blah blah blah. Ceftriaxone is something which is easily available, not that expensive, easy to administer, available even at a district. So someone who wants to go home, you keep the IV line, send the patient home, ask them to take the antibiotic back home. So ease of availability on those things, that is where it is. And as said, it's more about kind of that peace of mind that or that guilt consciousness where you said that you still did what you can do, and if still endocarditis occurs, probably it's unfortunate kind of a thing. But really going with this thought process, probably pertinent, but practically speaking, not able to apply it.
Okay, all right. Thanks, Praneeth. Anybody else has any other thoughts? I will unmute Dr. Sahiti. Dr. Sahiti, you have a question, but before that, if you could just share your thoughts on the discussion that is happening, and then you can put on your question. I have unmuted you, Dr. Sahiti.
Yes, sir. Good evening, sir. Actually, I have one doubt. The patients with who is suppressive immunity condition, along with valvular heart diseases, does we have to give any infective endocarditis prophylaxis? Hello.
Yeah, Dr.
Yeah.
Sahiti, before I let you go, I heard your
Yes.
question. We'll address your question.
Okay, sir.
Before I let you go, I want to know your thoughts on immunocompetent patient. Immunocompetent patient, valvular heart disease, let's say MVP. Do you recommend giving antibiotics to these patients?
Yes, sir.
Okay. Do you have this concern? I'm sure you are dealing with a lot of antibiotics. Do you have this concern about antibiotics being misused or giving too many of them with no documented benefit?
Yeah, if we give too many of antibiotics, there is a chance of adverse drug reactions also, sir.
Okay. All right. Praneeth, could you address her question? Her question is particularly about immunocompromised patients getting endocarditis prophylaxis. Like we discussed so far that most of us have a very low threshold of giving prophylaxis for these patients. Does it really change if a patient is immunocompromised?
Not much, but patients who are immunocompromised, you will be more favoring to give antibiotics or an endocarditis prophylaxis for them, because you believe they are more at risk of any infection. So is endocarditis. So giving endocarditis, you have much lower threshold than giving antibiotics.
Perfect. Thank you. It's 8:32. We are past our time. Anybody else has got any questions, comments, or thoughts about this particular topic that we are discussing? I will tell you my thought process. I am in line with all of you. The only thing which I'm not doing is I'm not giving antibiotics in pre-operative angiogram patients. I never thought of giving, and after discussing this, I may have to revisit my thought. I'm young enough that I can learn new things, so I have to revisit that thought and see if there is any rationale of adding that, which I'm committing right now that I have not been doing so far. It only makes sense to me that if we are giving antibiotics for, let's say, dental manipulation, then we probably should be giving antibiotics even for invasive angiogram. Although none of the guidelines, even early 2000s guidelines, never recommended giving antibiotics in angiogram cases. So that is my thought on it. Anybody else has got any other ideas or any other thoughts? If not, yeah, Praneeth, you have your hands raised. Is there anything that you want to add?
Yeah, so none of the participants at least discussed about the role of oral antibiotics, and so I believe everyone is in agreement to give IV antibiotics alone, and probably oral antibiotics also don't have much of a role in endocarditis prophylaxis. That's what I believe.
Yeah, so truly speaking, again, if we are going outside of the guidelines, then see, guidelines don't mention IV antibiotic superiority over oral antibiotics. So we really don't know that aspect. So I think it all boils down to comfort level. And what you said is that IV works better because you have given it. I remember uh, in emergency, when patients come who need steroids, we all talk about IV versus oral steroid, realizing that the time of onset for both are the same. But still you choose IV because you have given it, versus oral you take, God knows what happens in the stomach, patient may vomit later on. You have no idea where the drug went, where it did not. So IV will have a rationale more of related to, again, that peace of mind, so-called, or the surety rather than the efficacy. I particularly don't believe that IV will be any additional benefit at a molecular level. But that's just my impression. But as I said, I would still IV because of that surety. Okay. Dr. Srinivas Akula, your final comments, and you joined us for the first time in this session. It's kind of a different format that we have where we just have a casual discussion rather than a formal presentation. What is your thought process about this format? Do you think it adds a different value? If you could give us some constructive criticism about this kind of format.
Yeah, this is really good. I appreciate the efforts behind this, both you and Dr. Praneeth. See, we were talking about hospital setups only. I have one thing to tell you. See, definitely in a clinical practice where outside all the dental clinics are small areas where they don't have emergency setups also. Some people don't even have an emergency kit also. So those areas, it is really difficult to manage with IV antibiotics. There won't be any trainers to put an intracat or anything. So most of the places I know, out of 100, let me say 95 to 97 places will give oral antibiotics only. And we have cases uh, coming into our hospital or ER having fever for 4 days, 5 days post extraction and all. So, uh, so choosing between IV and oral, I don't know where will we stand.
Sir, when we do give oral antibiotic, what is the drug of choice that you guys are using, or in the peripheries, what do you see being used?
2 grams amoxicillin.
2 grams amoxicillin. So that is the pretty standard
Yes,
drug
standard.
choice that
Yes.
the guidelines have recommended.
Yes.
Dr. Chandramukhi, if I could get your final comment about the session and about the topic, anything you want to add, and then we'll have Praneeth close the session. Dr. Chandramukhi.
Yeah, this was like very informative session, and we had some doubts which got cleared off. I have one more doubt that in patients who are receiving higher antibiotics for any other infection like Magnixfort or imipenem, meropenem. So in these cases, if the patient is going for any invasive diagnostic procedure or any other procedure, so what will be the infective endocarditis prophylaxis in these cases? As already you have mentioned that we are not very sure, like because of the chain of the spectrum of the etiological agents of infective endocarditis. So whether in such patients do we need to give like ceftriaxone or any antibiotic to be given at all before the procedure because they are already receiving higher antibiotics. So how should we go about these patients who are already receiving higher antibiotics? And one more thing, like you were discussing about the patients to receive infective endocarditis prophylaxis before diagnostic angiogram, because we will be doing most of the echoes for patients who are having infective endocarditis. I myself have seen 2 cases, like after the PTCA and even after the angiogram, who was having, one patient was having aortic stenosis and who got infective endocarditis of the aortic valve, and later he has to get operated for infective endocarditis of the aortic valve. And one more case had infective endocarditis after the angiogram. So when we see such cases, and one more case I had seen that after root canal treatment, this patient, native valve patient, the mitral valve prolapse with MR, this patient also had infective endocarditis after the dental procedure. So when we come across such procedures, even if these procedures or there is no like mention of these situations in the guidelines, but still we prefer to give infective endocarditis prophylaxis in these procedures also.
Perfect. Thank you so much, ma'am. Truly speaking, I don't know the answer to your question. I'm going to ask somebody, let's say Dr. Srinivas Raju, if you could just share your thoughts. Patient already getting meropenem requires some invasive procedure. Dr. Srinivas. I think, okay. Praneeth, if you could you answer this question? How would you approach this case?
I probably won't give the patient another dose of antibiotic, because already the blood levels of antibiotics are already there, and those are high-end antibiotics. So I would continue them the same antibiotic which is going in, no additional dose of antibiotic for them. That is my thought process.
Yeah, so the idea is very simple. You are trying to cover for staph, strep, and enterococcus. And if the patient is already on high guns, which will cover these, of course, they will not cover MRSA, but then we are not targeting MRSA. It should be okay. But if there is high index of suspicion for MRSA, then you will have to give vancomycin, and that is the thought process that I was questioning earlier. That if we have to prevent, then might well prevent with a drug that we know will actually work. We are well beyond time, so I'm going to close here. Praneeth, your final comments on this, and then we'll close the session.
Yeah, so it was a good session for me. This is at least one area where most of us are not comfortable following the guidelines, and we have our own thought process and practice patterns, and I'm glad most of them are in the same agreement. But it probably takes some time for the thought process to change or the practice patterns to change to adopt the new guidelines and reducing the indications or the usage of antibiotics, because we are equally worried about the antibiotic resistance and all. But as said, probably in discussion with the surgeon or like a dentist or the person who is operating the procedure, knowing what exactly they are doing, some of them were enlightened. Like the dental procedures, I am not aware. Like what Dr. Srinivas have said, these are the procedures and what they do and what they don't do. If we know exactly, paying more attention to what procedure is done and whether there is any break of that endothelium, we can be more comfortable or avoid antibiotics in some situations, and probably be reducing the usage of antibiotics. This is what I could think of, and I thank each and everyone for their comments and their thought process. It was indeed a good discussion.
Thank you, Praneeth, and thank you all for attending today's session. To the attendees, particularly those joining us for the first time, we would like to get your feedback for the session. If you found the session worthwhile, may we request you to share it amongst your colleagues, since the general motive is thought sharing with as many people as possible. As I mentioned before, the Huddle is hosted every Wednesday at 7:30. The link to join the Huddle in the future is the same, so you can use the same link for the future session as well. All the Huddle sessions are recorded, which means I have the audio recording with me. I can share it with you if you just shoot me an email. They're also available on podcast on YouTube. You can just search the weekly Huddle and you will get the respective links. So that also you can subscribe to or just download from the web. I thank you again for your time participating in the discussion. Thank you particularly Dr. Srinivasakula for joining. Good night, all of you, and see you again next week. Thank you all.
Right. Thank you.